Welcome to our PG teaching session, e-Gurukul. Today we have a case on hematology system. And for this case presentation, we have Dr. Praveen Shahu from GMERS Medical College, Gandhinagar, and his mentor, Dr. Nisha Upadhyay. She is an associate professor in the Medical College, Gandhinagar. I welcome Vaibhav Shah sir and Baldev Prajapati sir to please take the session ahead. And I request Nisha to please introduce Dr. Vaibhav.
Sure, ma'am. Good evening, everybody. I'm just welcome Dr. Vaibhav Shah. He is a renowned pediatric hematologist, oncologist working in RV Hospital, Ahmedabad since last 3 years. He did MD in pediatric from VS General Hospital and fellowship in pediatric hematology, oncology from Sion Hospital, Mumbai. Currently, he's working as a BMT physician at SIMS Sankalp BMT unit, where treated more than 200 patients of thalassemia with allogenic and haploidentical bone marrow transplant with successful outcome. He has experience of more than 5 years in treating children with any hematology and oncology related issues. He had been a part of NGO helping children with thalassemia as well as hemophilia. He gives his honorary service to poor patients at LG Hospital and Civil Hospital in Ahmedabad. I'm warm welcome to Dr. Vaibhav Shah.
Thank you so much, ma'am.
Thank you so much, Nisha. We were missing Baldev sir for last 2 to 3 sessions.
Yeah.
Now sir is here again to guide us all. So I once again welcome sir. Thank you so much for being here and taking us through the journey of learning. Praveen, all the best for your presentation. Please start.
Thank you, ma'am. Yes, yes.
Sir, platform is all yours.
Good evening, friends. Welcome to this our popular PG clinic, e-Gurukul. By the, I will say, most efforts from Dr. Nehal and her team. Dr. Praveen is the presenter. I request Dr. Praveen, you can call your colleagues to join on the screen as a panelist link so that I think we can have more interactions. You must have some other colleagues also from your place.
Sir, I'm asking other students to join.
Okay. Anyway, meanwhile, we'll start with this Dr. Praveen's presentation. The flow, usually what we do, the diagnosis is not the important. We will try to understand that what type of the situation related to that particular patient. How we should think, that is very important. What is our thought process? Diagnosis probably may be the same condition or some other condition. And it is never, I will say, important. Our main idea or goal or aim of this PG clinic is to spread the particular idea that we should have the thought process. What is our think process? So I think with that, I request Dr. Praveen to share his PPT and start the history part.
Yes, sir. Good evening, everyone. Sir, can I start now?
Yes, sir, please.
A 6-year male child named Popat Patelia, who belongs to Satnampur, subcaste Kodi and Hindu by religion. Here, informant is Champavan, mother reliable, and child himself also. Presented with chief complaint of fever since 1 day and pain in bilateral lower limb since 1 day. Coming to history of presenting illness, a patient is a diagnosed case of sickle cell anemia and asymptomatic since 1 year, presented with fever, which is acute in onset and low grade and intermittent in nature, relieved on medication. No diurnal variation was present, not associated with any chills and rigors, not associated with any pain in abdomen, vomiting, or sore throat. Patient has pain in bilateral lower limb since 1 day, which is acute in onset and progressive in nature, which is sharp shooting in character. There was no radiation. when pain present in all over the joint and lower limb and in lower limb, more in smaller joints of lower limb. Was not associated with any swelling, any weakness in lower limb, or no restriction of movements. Not associated with any stiffness and any rashes. No history of trauma or fall. There was no history of any bleeding from gum, oral cavity, ear, nose, or bleeding per rectum present. There was no active bleeding, no history of any craving for inedible substance or passage of worm in stools or origuria, nocturia, or bony abnormalities. Coming to the,
Dr. Praveen, can you just stop sharing?
yes,
I think whatever information you have provided, let us try to understand.
I think go back one slide.
Yeah.
yes,
I think you have made the very bold statement from the beginning that it's a diagnosed case of sickle cell, right?
yes,
Just you can stop sharing. Yes.
yes.
There is no need of slides. Slides will again will be back to slides later.
Yes.
Forget regarding these known case of sickle cell. Many times it may happen so that first time patient has come to you
Yes, sir.
and we do not know any the background of the patient regarding the diagnosis or so. And you are sitting in the OPD, and in the OPD, suppose the patient is brought with this complaint of fever and pain in the lower limbs. How we will think?
Sir,
Because as I say, already diagnosed that condition, we are not aware of it. First time the child is brought to us.
yes, sir. Sir,
I
it is
think, are there any other students with you?
Yes, sir.
Okay, Dr. Rajat is there. Okay. Rajat, I think you can take it. Then we'll be back to Praveen because Praveen must be knowing all the details. I hope that you have attended from the first slide. It's a 6 years old male child. And child has presented with fever and pain in the lower limbs. Already he has mentioned that it's a diagnosed case of sickle cell, but what I said, forget regarding the diagnosis. Suppose we are not aware of it. The first time child is brought to us and you are sitting in the OPD. What will be your thought process? Fever and pain.
So first we try to different. So first we'll try to differentiate whether that pain in the lower limb is a myalgia or a arthralgia.
Okay, how will you do? You can do. What information you will gather?
So like we can ask like where is the site of the pain,
Okay.
then the aggravating or the relieving factors. So the site of the pain will give us a clue, such as like if it's in the calf and all, then likely to be a myalgic pain. If involving the joints, then likely to be arthralgia.
Rather, just listen to me. Suppose the pain is in the muscles, fever, and this pain is in the muscles. No bone is involved, no joint is involved. And even child is finding difficulty in walking also due to the pain.
So then in case of that, then it will most likely suppose can be a viral myalgia.
Okay.
Or then we can ask like when is the pain whether the child is having difficulty in getting up from sitting position or difficulty in walking.
Suppose
Based on that we can see whether the
Rather, for the clarity, let me give you some scenarios. Suppose in the present scenario,
yes,
that's within this particular seizure, child is brought to me in the OPD that started with a very high grade fever, with even mild chills. And at the same time, child is complaining of the pain, even as a whole body ache, what they will say. That even the lower limbs, muscles, and even child is having mild rashes also. In the OPD you are sitting, what will be your thought process?
so can be dengue.
Yeah, that's the thing which you should consider. I think in this season, that thing should come to your mind first. Any viral, but more so particularly in this particular time, epidemic or what things are going on, probably you may consider. Or suppose if it is not dengue, what else even? Suppose somebody had done NS1. NS1 turned out to be negative. And the fever is very high grade. And particularly even the patient is more of the bone pain or even the joint pain. Even the child is not able to walk. Sometimes you are not able to.
So then it can be,
Yes. Rajat, come on.
so chikungunya can be one.
Yeah,
Chikungunya can be a possible.
we should go to the next, that who is the cousin to this dengue. Right, and all of us know that chikungunya can also present in this way. Okay, anything else? Now go beyond that. So dengue can be there, chikungunya can be there. Something else beyond that, Rajat? What you are discussing? Something else? Suppose
So
in
acute rheumatic fever.
other way, if I put it, the child had this fever and some mild upper respiratory manifestation few days back. I think that subsided. And now the child has come to us with the pain in the lower limbs and so much pain that not able to walk even. What it could be. And not uncommon in the practice.
So acute rheumatic fever.
Rajat, your voice is breaking.
Acute rheumatic fever.
Okay, acute rheumatic fever.
So acute rheumatic fever.
I said here now no fever. Fever was there few days back. And some respiratory manifestations. It subsided. Now the pain and so much pain they're not able to walk. I think somebody put on the chat box very rightly. Let me see. That person has put the viral myositis. And not uncommon. And you know that even the child may not be able to walk so much. Even many times the people will think some neurological condition. And it's not uncommon. Okay. Suppose all these conditions are not there. Fever is not there, but the joint pain. What it could be? What things will come to your mind? Dr. Praveen?
So then it can be like juvenile idiopathic arthritis, JIA.
Okay. Okay. In 2 days' time?
Yeah.
Only 2 days' time we will consider. What usually they say that juvenile idiopathic arthritis. What is the common duration?
That's more than 6 week duration.
Exactly. At least in weeks. And if it is even the juvenile idiopathic arthritis on day 2 or day 3, nobody can say. Nobody should go for this diagnosis. It's first common. And suppose if you fail, and it persists even, or even progressive, then you will think, oh, it is something else. And then it continues for weeks together. Then I think you, in a differential diagnosis, juvenile idiopathic arthritis should come. Not on the second day. I think not even the rheumatologist should consider. Right. Anyway, as you said, sickle cell is a diagnosed case. Similarly, I will say some hematological condition is diagnosed in the past. And now the patient has presented with a joint problem. What it could be? I came to know later on that yes, it is diagnosed some hematological condition.
Hemophilia can be there.
Yes, hemophilia can also present in this way. Absolutely.
If sickle cell also, there will be in crisis also, we can come with pain, sir.
Absolutely. That is also possible.
In case of
Right.
osteomyelitis also can present with fever and joint pain and also pain also, sir.
Right. Or even some other, suppose the patient is having the fever of some days or some weeks, with their child is sick looking. Child is having the joint pain. And patient is even on examination, you may get some skin lesions, bleeding skin lesions. And even the lymphadenopathy, what it could be. I think keeping the general conditions, common conditions in your mind. That the child is having high-grade fever with a sick-looking child. And the child is complaining of the joint pain or the bone pain. More so, even mother may complain that more so in the night time. And even on examination, you got some bleeding skin lesions. And even you on examination, you got some lymphadenopathy. Which should think come to your mind? And not an uncommon condition, I'm asking.
Reactive arthritis. Reactive arthritis.
Why,
Sir
why,
is
why the
asking
patient,
about hematological condition.
even suppose reactive arthritis, rather if you are thinking, why the patient should be, in the what happens in the reactive arthritis, commonly one joint is involved. Usually large joints are involved. Here what I say, not even the joint pain, but probably on details I got that is the bone pain. And mother complained that this pain is worsening during the night time. I think I've given the very
And even
important clue.
bleeding rashes also sir mentioned.
Scurvy. Scurvy.
Okay, I think Rajat, this is
Or
the thing.
leukemia.
Why or leukemia? Leukemia should come first. In the scurvy, why the child is sick looking? Child is not sick looking. In the scurvy, yes, joint pain will be there, but usually not lymphadenopathy. Right. So, and scurvy, somehow now it has gone down. Probably when we were students, yes, we used to come across, but now it has gone down. So I think that's the thing. Dr. Vibhay, you can take it further.
Yeah.
While
No, it's
I'll be back.
perfectly fine, sir. So fever with joint pains. Suppose we forget the history of sickle cell disease. As sir mentioned, I think we should proceed as a generalized. Even though there is a one precipitating history is there, it can be as good as a normal patient coming with fever with joint pain. And acute leukemia is more importantly, precisely, they do present with single day fever and joint pain, which is bone pain like condition as a history. So that could be one possibility. Second, as sir very well described, all infective causes has to be ruled out. So fever with joint pain, yeah. Then coming to this patient, this case got a diagnosis of sickle cell disease, as we all know. So what else should we ask for?
So we'll have to ask for other complication like dactylitis
Yes.
or rule out acute chest syndrome like any difficulty in breathing or cough, lower respiratory signs.
We are focusing right now just with fever with joint pain. The presenting complaint is joint pain and fever in a sickle cell disease. So what are the precipitating factors?
The precipitating
So
factor means
usually dehydration, acidosis, or infections,
Right.
or
any exposure to cold environment
surgery,
or hot environment.
any stress.
Right. So we should rule out all the precipitating factor related histories first when we know the diagnosis. I think you mentioned it was diagnosed and asymptomatic for 1 year. That was little bit confusing to me. So when was patient diagnosed? Is it a upfront diagnosis or it's a chronically diagnosed patient?
Sir, actually, it was diagnosed at the age of 1 year. Then
Okay.
patient was asymptomatic till 4 years. Then at the age of 5 years, he got this similar complaint of painful limb. Then he got a PCB transfusion. And 1 year he was completely asymptomatic. After that 1 year, similar event occurred. Sir. This time he presented with pain and fever.
Correct. So now suppose this patient we don't know it was a sickle and came to us as 5 years and we saw the hemoglobin was low and we got diagnosis of sickle, and this joint pain, specifically more pain towards a lower limb and difficulty in walking, what should be the first thought come in mind?
Sir, at
Suppose
first,
patient doesn't have fever. This patient doesn't have fever, only lower limb pain with difficulty in walking and newly diagnosed sickle.
first of all, a history of any trauma should be ruled out. Any trauma.
Right. Any correlation, any problem which is more common in sickle patients
Uh,
leading to difficulty in walking.
uh, uh, in osteomyelitis crisis, and also any
Crisis, yes, osteomyelitis can be. So another most common will be, I think we should suspect avascular necrosis of hip.
yes, sir,
And even sometimes they present with bilateral complaints also at diagnosis. Because it's during sickling crisis, there is interruption in the supply, blood supply, and it can lead to avascular necrosis also. So to predict whether this is a possible complication or not, patient is in crisis or not, what other histories we will ask patient?
sir, in history, a patient is not on crisis, or first, what type of crisis we should take after history, we will know that. In history, we will ask for any, there is any precipitating event is there or not, like fever and exposure to any cold or warm environment, then any stressful environment. And sir, if pain is there, there is any in pain in which areas? Pain, then sir, ask about the cough, symptom of any cough, any breathing difficulty, then breathing on exertion. Then sir, we'll ask for, is there any pain abdomen, or ask for any uh, left quadrant pain, sir, to rule out any other crises also, sir.
Sir, I think can we go ahead with history now?
Yeah. Now you can go
So
further
I
in
think,
the
yeah, you
more
can continue
information.
with the history.
More information.
Yeah.
In Sir, I should start from that past history of presenting illness, sir.
No, past history.
Already we have discussed. You can take it further.
Yes, sir. In past history, patient is diagnosed with sickle cell anemia, which is HPLC confirmed. At the age of 5 years, patient is presented with complaint of villus dislocation of uh, sclera and pain in the bilateral lower limb since 1 day, for which admitted in private hospital, and one PCB transfusion given. No history of any asthma, tuberculosis, and epilepsy or major surgery in the past. In family
Okay,
history,
wait, Dr. Pran. What other history you would like to ask in diagnosed case? This is a diagnosed case for since 4 years.
yes,
So what are the important past histories, which is very much important in this case?
uh, sir, in past history, sir,
Child.
Hello.
sir, in past history, we should ask for about any similar event in the past, any similar crisis event. If any crisis is there, which type of crisis was there, like it is panic sequestration crisis or a plastic crisis, or any in past history, any history of stroke also we can ask her.
Right.
And also, sir, in past history, any precipitating event that led to this event also we should be confirmed. And in past, any any blood product transfused, and how much transfused, in how much frequency it was transfused, we should also take care of, sir. Then any in past, mm, then we can ask about their in immunization. We can ask about their immunization history, sir. Any special immunization schedule taken or not taken, sir. In past, it also we should inquire about splenectomy done or not done, any surgery that will that will decide our
Does
any
sickle
chemotherapy.
patient have history of splenectomy?
No, sir. This patient did not have. No, no.
Even all sickle cell disease
No, sir.
patients, splenectomy is routinely done.
No, sir.
Okay. Then splenectomy is not important. Which other surgeries are important?
Um, because
So in past history, two important things we should ask. One is complication related to sickle cell anemia. So that includes all the possible crises, acute painful crisis, hemolytic crisis, past infection episodes, uh, priapisms, and all that things we should ask, especially in these cases. Second most common histories which we should rule out is treatment related history, which is very much important. A patient, what treatment has been given for sickle cell disease so far in last 4 years, what are the treatment he has received, because that again narrows down your diagnosis. If patient has been started on treatment, then painful crisis or avascular necrosis of hip is less likely. But patient undiagnosed, untreated, then these are the most likely possibilities. Patient has been put on chronic transfusion program, again the differential diagnosis will change. A diagnosed sickle with chronic transfusion program presenting with painful crisis is very less, versus a sickle cell diagnosed case without chronic transfusion, without any transfusion, is more likely to develop painful crisis. So two past histories are important. One related to the complications of sickle cell anemia. Second related to the treatment to the sickle cell anemia. And surgeries especially we look for mainly cholecystectomy. In families or family history will come later on, this is very young child, but they usually sometimes presents with gallstones, sometimes younger age. Again, avascular necrosis is less common, but adolescent patients coming to us with this type of feature, then AVN should also be kept in mind. Uh, Anything to add, sir?
So I think, Vaibhav, what I will suggest, let
Yeah.
him go in certain parts of the history, then we'll ask him to stop sharing so that we can even involve the other students also in the discussion.
Okay.
And that will be, I will say, because online we know that we are finding difficulty compared to the classroom discussion.
Correct. Correct.
Or bedside discussion.
Yes.
But very rightly, I think the important points in the past history we should include, and that's very important. Okay, you can take it further.
in family history, sir, it is a born to second degree consanguinity marriage. No history of similar illness in any other family members. No history of any blood transfusion in the family members. There is no history of any congenital anomalies, diabetes, hypertension in the family members. No history of gallstone or splenectomy in the family. Father is a farmer, mother is a housewife. Monthly income is around 2000, belongs to a lower middle class of Kupusame classifications. They lives in a kacha house with good ventilation, with boiled water for drinking and cooking. Uh, and there is no overcrowding present. Sir. This is the pedigree, sir.
I think you have mentioned 20,000 by mistake also. Really, is it 20?
It's 10,000, sir.
Okay, no problem. Take it further.
Sir. Pedigree.
What you want to show in the pedigree?
There is 5. Yes, sir. There are total 5 family members. Out of 3, first is female child, who is 15-year female child. Second is 11 years female child. Third is 9-year female child. This is the case who is 6-year male child. And then the fifth one is 3-year female child. No history of any similar illness in the family, and there is no history of any transfusion in the family. And no other family member has got any screen for sickle cell till now, sir. In antenatal history, mother is not a registered case. Patient taken iron folic acid throughout the pregnancy and pregnancy was uneventful. No antenatal screening done. No history of any major bleeding during pregnancy. Natal history, spontaneous normal vaginal delivery, full term, cried immediately after birth. No NICU admission. Birth weight was 2.5 kilo. Breastfeeding started within 15 minutes of delivery. Growth and development history have normal IQB in ACID for his good scholarship performance. In immunization history,
Rajat, I
Immunize-
think background noises are there from your side. Rajat, you can try to rectify it. Yes. Okay, Praveen, you can complete the immunization, then we'll go for the discussion.
yes, sir. Immunization according to national immunization schedule. That is BCG, OPV 0 dose have be taken. Then Penta, Rota, OPV 1, vaccinated IPV taken. Penta, OPV 2 taken, sir. Then Penta, OPV 3, Rota, vaccinated IPV taken, sir. MR1, vitamin A का first dose taken, sir. MR2, vitamin A2, DPT booster, OPV booster taken, sir. Vitamin A third dose, 4 dose, 5 dose, 6 dose, 7 dose, 8 dose, 9 dose taken, sir. DPT booster also taken. No special immunization for pneumococcal, meningococcal taken, sir. Nutritional history. Exclusively breastfeeding till 6 months. Complementary feed started at 6 months of age. Patient is vegetarian by diet. After calculating with 24-hour recall method, patient was found to be 14% deficit in calorie and 7% deficit in protein, sir. Coming to my summary is 7-year male child presented with complaint of fever since 1 day, pain in bilateral lower limb since 1 day, was diagnosed case of sickle cell disease, delivered to a second-degree consanguineous marriage, vegetarian by diet with 14% deficit in calorie and 7% deficit in protein, with immunization up to date, with normal development, belongs to lower middle class, sir.
Okay, now can you stop sharing?
Yes, yes, sir.
I think first other students. You have any question for Dr. Praveen? You want some more information or more clarification? I think so many other students are there. Please keep your video on. Please. Yes, Dr. Shwetangi, Dr. Ria, Dr. Dvicha, I think. Please keep your video on. Why you are reluctant for participation? I think Dr. Praveen, you said there is the yellow sclera in this patient. So was it jaundice?
Yes, sir.
What is the likely cause for this jaundice in this patient?
Sir, due to hemolysis.
Sorry?
Due to intravascular hemolysis, sir.
Okay. Why this jaundice does not develop in a case of thalassemia? Commonly, we don't get thalassemia, patient jaundice and sickle, yes. So what is the explanation? Why it happens so?
Sir, for jaundice to develop, sir, it should be in intravascular space. Hemolysis should be intravascular.
What do you mean by the intravascular?
It is not in the spleen or that extravascular space.
Right?
And also there is also decrease in production also, sir, in this case. That anemia is due to decrease in RBC production also, sir.
So it will cause the jaundice?
No, that's why not that much evidence on this. No, not more destruction rather than.
Anybody else? Can you explain that? What is the reason for the jaundice in a case of sickle cell? Which commonly we don't get in other varieties of hemoglobinopathy, like thalassemia, which is very common.
RBC got in sickle cell, RBC got sickle. So when they pass through the splenic circulation, that will got sequestrated, sir, and that led to that hemolysis in the splenic canaliculi. So jaundice
Okay.
will develop.
Okay, any other reason? This is one of the reasons, agree. Any other reason for the jaundice? Anyway, Rajat, anybody?
So decrease RBC lifespan.
Yes. There is a decreased lifespan in the case of thalassemia also. They also don't survive for this appropriate time. But commonly we don't get the jaundice. And sickle, commonly they have the jaundice. So what is the reason for that? I think let us take the help from Dr. Weber. Weber, can you explain, please?
Yes, so very well pointed out. Thalassemia, we usually don't get icterus because what is the pathophysiology of thalassemia? Can anybody answer?
Yeah.
What is the problem in thalassemia?
I think
So
purposefully
the
I asked
beta chain.
Yes, yes, Rajat, you can take it.
Thalassemia, it is a
Bit, bit,
I think Rajat's connection is lost. Rajat, he was trying to answer.
yes, sir.
Yeah.
Yes, what is the, you respond to Dr. Weber's question.
So yeah, so in beta thalassemia, the beta chain production decreases. So there is abnormal increase in the alpha chain production.
Right.
So this alpha chain, sir, will precipitate on surface of the RBC, which is taken by the spleen and they are lysed.
Correct. So what happens? So the problem lies at the globinization of heme part. So when hemoglobin is formed, heme part and globin part, at that level the problem starts. So your initial premature RBC level, even pronormoblast and giant pronormoblast, at that state they are unstable and they get lysed. So hemolysis occurs extravascular hemolysis occurs more commonly in thalassemia. Now coming to sickle cell disease, what is the pathophysiology usually?
So there's abnormal sickling of the cell, which will, so it is more likely a vascular hemolysis in sickle.
So they get sequestered inside the end arteries or small vessels. RBCs get sickled and they are getting sequestered in that vessels, and then hemolysis happens. So that is the fundamental physiology which is happening in sickle cell disease, right? So more kind of a intravascular hemolysis is happening in cases of sickler. While if you see the thalassemia, the more kind of extravascular, rather in the marrow, medullary destructions of the RBC happens. And as a compensation, hepatosplenomegaly happens. Body tries to produce more extramedullary RBCs to compensate for the chronic anemia. And that is the reason why thalassemics develop a huge liver and spleen over the time. Right? So that is the difference, and that's why we usually don't see icterus in cases of thalassemia. But in sickle, it is ongoing hemolysis is there. Uh, Sometimes very low scale, sometimes it goes aggravated with fever, dehydration, and all this precipitating factor. More RBCs get sickled, so more amount of hemolysis. In that case, your jaundice can get worsened.
So I think that's very important point what Dr. Weber has explained. And if you have the basic understanding, probably less of the confusions. You know, the thalassemia, what happens that before these cells are mature and come in the circulation, they are lysed. So there is no question of getting this jaundice component. While very characteristic in a sickle, what happens that knowingly or unknowingly, due to some milder factors of stress or dehydration or acidosis or something, which probably clinically may not manifest, but sufficient to cause the damage to these abnormal RBC, that is sickle RBCs. And therefore, continuously ongoing some hemolysis is there, and which results in the evident jaundice. And therefore, at any time, if you have seen the sickle, commonly we'll say, get the mild jaundice at any time, even with just patient has come in the OPD for routine examination without any complaint. That's not uncommon. And on the contrary, second, in a sick child with a sickle, another mechanism is hepatopathy. That even sickle can cause this damage to the liver. And then this hepatopathy, that is the damage to the hepatocytes. And that can also manifest in the case of the jaundice. So jaundice due to the multiple reasons, either it may be due to the continuous hemolysis, which may to a milder degree, or even it has caused the damage to the liver, and then it can cause the hepatopathy, and which will also manifest with some more manifestations of liver involvement. So that's a difference which we should be able to understand.
And one more, in a chronically transfused
Yeah,
sicklers,
naturally.
blood transfusion related hepatotropic virus infection, Hep C, Hep B, should also be kept in mind.
Yeah, and any child when is on the repeatedly the blood transfusion, we should keep in mind that beside the basic disease process, our iatrogenic problems are likely, and that can be in the form of some transmitted infections, or even due to some other, even the autoimmune problems. Because every time we are adding some antigens, and knowingly, unknowingly, it causes some even the autoimmune problem. That we should keep in mind. Second, you mentioned this consanguinity. But how will you define the consanguinity? Somebody is going to ask in the basic pediatrics that what you mean by the consanguinity.
Consanguinity can be first degree, second degree.
Rather, I think why there is some disturbances at your place. Can you manage it?
Yes, sir. Yes.
I think it is due to some your place or something. You can try to manage, please. Yes, Praveen, take it.
Sir, in consanguinity, it can be first degree, second degree, third degree, sir.
No, degree will come later on. First definition, what we mean by it.
Consanguinity means, sir, there will be marriage in related to our family members only.
What family members? On the contrary, broadly, if you understand, the Vasudeva Kutumbakam, they said that everybody on this earth is related. Broadly, you know what your Shastras say. So, but how you're in the medical understanding, we will define this consanguinity. That is very important.
Yes.
What I would say, what we related. Somebody is related in some other way. But when we give the importance, that means, medical disease disorders point of view, we are interested to know. Basically, if I give the idea, there is some genetical transmission. They are sharing the genetic material. And when the sharing of the genetic material, some disorders are common. From this point of view, we are interested to know. So up to what level the sharing is there of the genetic material. From this point of view, we should try to define the definition of the consanguinity. Anybody?
So it's basically a kinship with a relation who is descended from a common ancestor.
Yeah. How much?
Usually the great grandparents.
Yeah. I think Rajat has tried to answer it to some extent. It's that consanguinity defined as the marriage between the two, where at least there is one common ancestor, not beyond great grandparents. That comes usually third generation or so. And why? If you go for, because this genetic sharing, material sharing is common with these people. And then we go for the degree. Now you can take this question of the degree, Praveen. How you go for the first degree, second degree, third degree, and what is the importance of each degree, each grade?
first degree is between sir own brother and sister, sir, having same genetic material.
Right?
Then in second degree, one from uncle and uncle's daughter and brother. In third degree, uh, it is father to our grandfather's daughter's son, sir.
Usually cousins, right? And you know that why it is important. The first degree, they are sharing genetic material almost 50%. Second degree, there is a sharing of 25% of genetic
25%.
material. And third degree, 12.5%.
12.5.
So that's the important, that how we are interested to know this consanguinity. And suppose it is a reference to sickle, if you discuss, is it important? Is it playing the role in any way in a case of sickle, consanguinity?
Yes, sir. Sickling, chances of getting sickling is more common when the degree of consanguinity increases, sir.
Okay. What type of the disease it is, sickle cell?
Sir, it is autosomal recessive, sir. Mostly it is inherited in an autosomal recessive pattern, but
Right.
other patterns also there, sir.
Yeah, others are also there. And therefore, we should know that, the consanguinity, why we are interested either broadly, not with the sickle or any autosomal recessive disorders are common.
Sir.
Whenever consanguinity is there, keep in mind that this inheritance of the autosomal recessive disorders is common. And sickle is one of the, I will say, ways of the transmission of the disease, autosomal disease. That's why we are interested to know, right?
So, if this patient doesn't have a history of consanguinity, does it rule out sickle possibility?
Yeah.
No, sir. If there, then its chances is more, but if not there, then we should not rule out. It can be also there, sir. Because
Then what are the other ways?
sir,
De novo mutations can occur.
Okay. I think that question should be asked to Dr. Vaibhav. Right. Then what are the other ways of transmission of the sickle, if not the consanguinity? Dr. Vaibhav, I think you can take this point. Very important.
Yes. So consanguinity, if it is not there, even though in our country we are having very high prevalence of carrier rate, so that should be kept in mind. Almost India, even sickle, thalassemia, other hemoglobinopathies, almost 5 to 6% carrier rate is there in our country. So even though one person in Gujarat, one person in Delhi, still there is very high chance that we all are carriers supposedly. So if they two unknowingly marry to each other, even though they don't have the history of any positive sicklers in family or any thal major in family, still they can harbor the mutation, and they are autosomal recessive mutation harboring. So there is one chance. Second, as sir told, compound heterozygosis are very common. Some is harboring sickle mutation, other is harboring thalassemia mutation, or some other hemoglobin mutations. So in that case, double heterozygous states. So what commonly we observe is sickle beta thalassemia is very common, where one of the parent is sickle trait, other parent is thal trait. Right? So even though there is no history of consanguinity, this type of combinations also happen. Yes, they doesn't behave typically like sickle cell disease, but somewhat the symptoms are overlapping between sickle and thalassemia in that group of patient. So that is another possibility we should always keep in mind. So whenever we have a diagnosis or suspicion of any hemoglobinopathies, not only sickle, even thalassemia major or whatever, the parental screening is very much important to rule out what actually the disease is.
And I think what Dr. Vaibhav said is common in our country, that even the combination of these different hemoglobinopathies may not be straight away thalassemia or sickle. Yes, it is there, which will get, but whenever you are finding the difficulty, keep in mind that is there any possibility of combination? And several times we do come across that, yes, this is the problem. So that we should keep
Usually
in
it
mind.
doesn't happen with sickle, because if you see the HPLC, HBS is separately identified.
Yeah.
But thalassemia very commonly misinterpreted as a thalassemia major, but actually it is other combinations. HBE beta thalassemia, sickle beta thalassemia, that happens. So that's especially very much important. If you have a HBS of more than 50%, you are clear that it's a sickle most commonly. But anything other combinations, patient is transfusion dependent, then this combination compound heterozygous states, sometimes beta thalassemia trait with alpha gene triplication. This combination is also very common. They behave like a thalassemia major because the fundamental is same, alpha beta imbalance. Here also alpha gene triplication, so excess of alpha production is there, and beta thal trait, so underproduction of beta chain happens. So ultimately they behave like a thalassemia major or intermediate. And so even though you get HbA2 value of somewhat 4-5% and HbF of normal, still they can behave like a thalassemia major. Then you have to think about laterally about this compound heterozygous states.
I think you have mentioned regarding the IQ in this patient, Praveen. Would you like to make any comment or would you like to change it? In 6 years old child, what IQ you are going to assess? Anybody else? I think Dr. Pradeep, are you there? Shwetangi, please come on. You know, usually up to the age of 5 years, we go for the developmental quotient. And later on IQ is actually little bit complex phenomena. It requires a very specific trained persons, some psychologist or something. It's a little bit, I will say, complex methodology for assessment of the IQ. Routinely, probably in our clinical, we may not be able to decide this IQ of the patient. So that don't invite the trouble in the exam by mentioning some things. You know, best way even in the exam, once you are knowing that you are going to find some difficulty, better to remain away. Here what happens that you are admitting yourself, then the question will come, which may be probably difficult for us. So that is also very important, that how we should remain away from this, right? Okay, but I think in the summary, what you should make such a patient in the exam, now you know, after the history, they will ask you the summary. Summary should not be the repetition of the same information which already you have discussed. Summary, that means what is your interpretation? What is your inference from this presentation? Or what type of hypothesis you are preparing from the history? There may not be diagnosis, but you are preparing some hypothesis, your inference, your interpretation. I think that should come, and that should be very simple in 4, 5, or maximum 8, 10 sentences. No repetition of the same story. So, Praveen, would you like to make one more attempt?
Yes.
Give the summary of this patient.
My summary will be, sir, is a 6-year male child with a diagnosed case of sickle cell anemia, now presented with a pain in the bilateral limb with fever. So most probably he is having a painful crisis. He is going on a painful crisis.
Okay. So I think very rightly you tried. You can directly come over the point, because already you have made the statement. It's a known in the exam which happened, known case of thalassemia, known case of sickle. Very rightly you can address that with that, what is the present problem. And then you can make that already known case of sickle, which already diagnosed in the past, somehow remained with probably asymptomatic for some time, and now presented with a fever, which is likely some stress, and that stress has precipitated the problem, which particularly the limb pain or something, and therefore my presumption that it is likely crisis, and that should be the painful crisis. Then I'm sure that most of the people will accept us. And the only thing jaundice even you can explain, that jaundice is also noticed, maybe the part of ongoing hemolysis. Right. So I think that should be the summary. Any this type of case, make the multiple attempts that how you are going to describe the summary. Summary should not be the repetition of the same, boring, even the irrelevant points in the involving your narration. Narration should be short, sweet, very precise. And therefore, what always I say to the students, it should be ABC, accurate, brief, and clear. It should be very accurate pertaining to your case. It should be, I would say, concise, very brief, and clarity should come. Whatever I say may be wrong even, but this is my understanding. This is my interpretation. I think that thing should be there. That tone should be there in your description, and that makes a difference, right? Okay, I think with this, Dr. Weber, should we go for the examination?
Yes, sir. Yes, sir.
I think probably one point before you go for the examination. I think here immunization history is very, very
Very
important.
important.
I'm sure that somebody is going to take you in details of the immunization history. And if probably examiner does not take, you should take the examiner for the discussion, right? Keep some pause or some mention something so that you are tempting the examiner to ask the questions.
Yeah, I was about to suggest you can
Yeah.
add 2 points in your summary. One is adequately treated or
Yeah,
inadequately treated, and second is about immunization.
absolutely, absolutely.
Right?
I think
Because if patient is adequately treated, as I said, painful crisis and all that are lesser if they are consistently on hydroxyurea. So infective causes or other causes we should focus, vice versa. And as sir told, immunization, which is very much important in this patient. So these 2 points at least add in your summary.
I think Dr. Praveen, you have any idea that why this patient was not advised or really advised or not done, or why these vaccines are not given to the child? Because diagnosed at the age of 1 year, you say.
Yeah.
Yes, sir.
So any idea? You have at least gone in details?
Uh, they are not counseled about that immunization, sir.
Is it? Isn't it? Don't try to blame your colleagues.
Sir,
This kid was diagnosed asymptomatically, right? You told at 1 year without any symptoms it got diagnosed. So a pediatrician was pretty enough good to pick up the sickle
Yeah.
cell early. So
And that was a good time even.
yeah.
Now, which vaccine? Anyway, suppose you were the person. Which vaccines you will advise? Let us take in this way. Forget regarding this who advised, not advised, done, not done. But suppose you are the person and already you have diagnosed the sickle cell, you are discharging the patient. What advice you will give for the vaccination?
In vaccination, sir, pneumococcal conjugate vaccine should be advised, sir. We should advise for that pneumococci and meningococci for
No, first
vaccination.
suppose pneumococcal.
Yes,
Take
sir.
this, explain me in details the pneumococcal vaccine.
Okay.
Which vaccine
Sir,
or which numbers of vaccines? How many doses? What is the interval? How it gives the protection? Explain me in details regarding the pneumococcal vaccine.
in PCV10 and PCV13 pneumococcal conjugate vaccine, sir, it should be given in first if the child is less than 1 year, then it will 3 schedule is given, sir, at an interval of 4 weeks, sir.
Dr. Praveen, that's why purposefully I asked the question. And my purpose is, sir, you know that the pneumococcal vaccine is advice is not sufficient.
Yes, sir. And it should be, sir, after that there is a booster dose in the 15 at the age of 15 months, sir. Then after 2 years of age, then it should be continued, sir.
Anybody else would like to take it? Shwetangi? Somehow she is remaining away from this screen. But I remember that Dr. Asmita has participated in the past. Dr. Asmita, can you come, please? Can you explain that in a diagnosed sickle cell patient, how will you advise details of the pneumococcal vaccine? And I think this is very vital point. Somebody is going to go in the details. Even any other student, come on, if it is wrong, no problem. Dr. Pradeep. Rajat, are you there? Dr. Ria?
Yes.
Yes, Rajat. Come on.
Sir, both vaccines should be given conjugated and polysaccharide vaccine.
Okay, Shwetangi. But at how many doses? Which
Not
one?
sure of the dosage.
Which one first? Conjugated or this polysaccharide?
Conjugated should be given first, then polysaccharide.
Why? Does it make any difference? Some pediatricians will say it was there with the polysaccharide, so I give the first one. Conjugated, I will read the next time. What is wrong? That's why I'm asking the question. All this clarity should be there with us. And what is age of the patient is also very important. Suppose any patient diagnosed as 1 or 2 years or 3 years, then see in the past how many this really they received any pneumococcal vaccine. Then your schedule will be changed. And suppose no pneumococcal vaccine is given, then your schedule will be different. What I want to explain, please remember, in this type of the patient, suppose 1-year-old child and 1 dose of the conjugated or 2 doses or suppose 3 primary doses of pneumococcal vaccines given, conjugated. Which conjugated vaccine is advisable? PCV10, PCV13 you say, or any will do?
PCV 13.
13.
Why, Rajat?
More number of strains are getting covered.
Please remember, for immunocompromised children, whenever the pneumococcal vaccine comes, only PCV13 is recommended. Then there is no choice. In routine immunization, you have the choice. In immunocompromised children, only PCV13 at present is recommended. Number 1. Second, suppose if you're already given or child is more than 2 years, then 1 dose of PCV13 and first conjugated. The reason is, if you are given the conjugated first and later on if you go for polysaccharide, there is difference in the amount of the antibodies produced by the polysaccharide. So first conjugated. After this conjugated vaccine, suppose if you are given, after 4 weeks, preferably 8 weeks, you should go for the polysaccharide vaccine. Conjugated 1 dose is sufficient after 2 years, but polysaccharide 1 more dose can be given after 5 years of the first dose, and never the 3rd dose of the polysaccharide. Please remember, not the 3rd dose. So this is a very clear schedule for the pneumococcal vaccines. Meningococcal, yes, you can give it, but we are not sure how about the protection in the future. Regarding, I think somebody mentioned on the chat box that when we were discussing, I missed the point, that even the osteomyelitis due to salmonella is common in the sickle cell. Is it right, Dr. Praveen?
Yes, sir.
Why? And suppose this already typhoid vaccine is available, conjugated, is it the same? Will it be able to protect the child from the future osteomyelitis due to salmonella? Most of the books have mentioned, but not so. It is said that the sickle cell salmonella species is different from the salmonella which is causing the typhoid. So it is chance, but still this can also cause it, therefore we give it. But at the same time, from different salmonella typhi, for which we don't have the vaccine, child can develop the osteomyelitis. I think so details we should know. And all the polysaccharides vaccine should be given because polysaccharide organisms are more responsible for sepsis in these patients. Now the second question will come, this is whether they are splenectomy. I think Dr. Vaibhav was discussing the sickle cell, usually they are not splenectomized child. I will say they are the splenectomy children. Am I right or wrong? Shwetangi? I
Yes,
think.
sir. Yes,
Right,
sir.
sir.
What is your response?
Autosplenectomy is there, sir.
Absolutely. The spleen is there, but function point of view it is not, I will say, competent enough. Therefore, almost I will consider that is splenectomy status. And then the question comes, another question. One child was having the road accident, rupture of the spleen, and an emergency splenectomy was done. Another child is having either the spherocytosis or even the sickle, and here the child is autosplenectomy or something, whatever the status. Does it make any difference of the response to the vaccine? Or both in both the situations, response will be the same? Any idea? Anybody? I hope my question is clear. The two different situations, both the children don't have the spleen. One child healthy and hearty, normal child, unfortunately met with this road accident, rupture of the spleen, surgeon had to remove it. Another situation, diseased person, and then the spleen is not functioning properly. I am giving the vaccine in both the children. Whether the immunity point of view, whether the effect is going to be the same or different.
Are different.
What is the difference, Shwetangi? Then we have to
Sir, in
answer.
traumatic ruptured spleen, there are chances of remaining spleen is also there. Some amount of splenic function. If it's not complete splenectomized patients.
Total splenectomized. Let me answer. Total spleen is removed. Shwetangi. Still, if I help you, still it makes a difference. Come on. Then you explain how.
Sir, in splenectomy, we are planning to do splenectomy, so we can give prophylaxis before doing that.
No, let me make the point clear, which you can remember. Usually in a plant case, plant surgery, better to remove the spleen after the age of 5 years. Suppose spherocytosis, and I have to remove the spleen. I will request surgeon that please wait up to the age of 5 years. Why? Because the presence of spleen up to the age of 5 years, its function as the immunological functions are very much mature. And later on, the response to the vaccines are very good. Chances of infections goes down. While in a disease spleen, it is said that is immunologically not competent enough. And in spite of my vaccine, not sufficient able to give the protection. That's the difference. And it is said that in a healthy child, the spleen is removed. There are the 50%, 50 times chances of developing the infection, where in a disease spleen, 350 times chances of development of the infection. So that's a difference. That means in a healthy child and immunologically weak child, it makes difference in presence and absence of the spleen and even the response to the vaccination. So I think all the details are expected from the pediatrician, because pediatrician is a specialization from growth, from the development, from the nutrition, and from the immunization. I think here you should be the very competent enough, which probably physicians may not be there. And all the details will help you. Second point, after this, even the vaccination, should I go for the prophylaxis or neither? No need of the prophylaxis. Already I have given the vaccine. Somebody advised the prophylaxis. Patient is brought to me. Sir, is it necessary? Already we have given all the vaccines according to their advice. What is the answer? Shwetangi? Dr. Praveen? Anybody? Dr. Asmita? What is the recommendation?
Sir,
With the splenectomy. Yes, Praveen?
with the splenectomy means splenectomy is generally done after splenic sequestration crisis. Then we have to continue the prophylaxis, sir.
Why? In spite of the vaccination? Then what is the role of vaccines? Yes, come on. The point is, yes, even with the vaccination, prophylaxis is required. Best prophylaxis is penicillin. Penicillin V, what we say, I think campaign or some trade name is there. And that is 250 milligram BD. Some people say up to the even 5 years after the splenectomy, but ideally it is a lifetime. Because at what time the pneumococcal sepsis can develop and kill the person, we don't know. So I think these are the points for the vaccination. We should go in the details. Any of the questions can come. And even from the practice point of view, they are important, not only from the exam point of view. Is there a relationship between the sickle and malaria?
Sickle cell trait, people are resistant to P. falciparum, so they are protected from P. falciparum.
Is it?
And
Let us
Yeah,
take the help of Dr. Weber. Is there a relationship between the malaria and the sickle? And what is that relationship?
So if you go in the history of the sickle long back, actually sickle was a defense mechanism against the malaria prevalent areas. So it was a body's adaptation, genetic mutations happened in case of heavily malarial endemic areas. So their genes got modified and it was a kind of a defense mechanism. So as you told, it's right. Sickle usually protects from the malaria. Sickled RBCs are not good media for malarial parasite to survive, because we all know that malarial parasite survives inside the RBCs, but the sickle RBCs are not good medium for them to survive. But practically, if you go, we are seeing the cases of sickle in with malarias. So it's not like now malarial parasites also had some genetic mutation, we don't know. So they are able to survive in sickled RBCs. But long to the history, it was the thing.
Yeah.
So they are immune, but we are seeing the cases.
I think very appropriate, Dr. Weber saying. Please remember that yes, some protection is there compared to other normal population. You may get the less chances of malaria, but it does not this exclude that malaria is not going to be there in a case of sickle. Yes, it can be. But yes, compared to the general population, his chances of malaria is less, and there is some protection. From this explanation, what he said, that there is some genetical, in short, it is not favorable situation for the malaria parasites in these RBCs. And therefore, there is some protection. I think these are the some points which we should know, which may be helpful in the practice also. Anyway, Dr. Praveen, I think sufficient time we have taken for the history. And always let me re-insist that history should always be details. In any case, more than 80% diagnosis should be revealed from the history. 20% probably I will go for on the examination. And after this, my clinical diagnosis, I will plan for the investigations. Never the investigations first. On the contrary, Dr. Praveen, before you share this your PPT, let me ask one more question. I think I am interested for other students because you must be knowing the case in details. But I think the person who is not knowing can participate in a better way, like me and Dr. Weber, that we don't know the case. And even sometimes I don't know the system also. And then I think probably there will be a good discussion. What you say, hematological condition may not be necessarily hematological condition. That may be something else, right? Anyway, what you are expecting on examination in this patient, that question should come to our mind. Before I examine, I will make up my mind that what things are expected when I examine the patient, or what specifically I will check for, whether this particular finding is there or not. And that will help you a lot. Let us come on, I will say the person who has not seen the patient. Anybody? Shwetangi, would you like to take it? That what you're expecting in this patient when you go for the examination? Or Dr. Asmita? I think.
Taylor, sir.
Yes,
first.
Shwetanji, come on, yes. One
Pallor.
thing, without any hesitation, please you continue whatever comes to your mind. Dr. Vaibhav is there. I'm also not afraid because if I do some mistake, he's there to rectify us. So no problem. So maybe the pallor, anything else? I will start from the general findings, then on specifically liver, spleen, something like that, or even some bone problems. What you are expecting? Okay, Praveen, you can take it. Even whatever you have found on examination, but what you are expecting.
Sir, in general examinations, there
I
must
think
be
first
some.
I'll take the point what Shwetangi had mentioned. Pallor, is it right? You are expecting the pallor in this patient?
If any aplastic crisis or present with any splenic sequestration crisis, then
Yeah,
failure will be evident, sir.
may be there, but may not be in all patients.
Yes, sir.
Okay, then what else?
But
If
here
there
we
is-
are suspecting painful crisis more.
Hmm.
So when does painful crisis happens in sickle? With severe anemia or vice versa?
Sir, painful crises are more in case of any precipitating factor like dehydration or cirrhosis.
No, I am talking purely in term of hemoglobin
Anemia.
levels.
Yeah,
Okay.
anemia. Vaibhav says
So
that
with
what is like expected level of the hemoglobin? Not
Uh,
yeah,
exactly
lower the
percentage.
hemoglobin more will be the painful crisis, or higher the hemoglobin more will be the sickle crisis,
Yeah.
painful crisis.
It is a part of viscosity syndrome. So more the hemoglobin, more will be the painful crisis. Chances vaso-occlusive crisis will be more in that case, sir.
Yes, so painful crisis happens more when their hemoglobin shoots up, right?
So you may
So
not get the pallor
yeah,
or mild pallor. Right. So I think here in this patient, pallor may not be the significant finding. What I mean to say, attention drawing finding. Of course, some degree of anemia is going to be there. Then what is regarding the another thing you can mention, jaundice. Whether you are expecting jaundice in this patient?
Sir, yes, jaundice should be there, sir.
Yeah, that it should be there commonly. Then what is regarding the vitals point of view? Temperature, pulse, respiration, blood pressure, take it this way.
Yes, sir. Sir, then chances of we will look for any pigmentation also, sir. Knuckle pigmentation, any angular cheilitis, sign of any vitamin deficiencies also, sir. That
Very
after
good.
that, sir, we will look for any because it is presented with fever, so temperature we should check about temperature. Then also pulse. If there is an if the child is presented with any sign of failure, in that case, sir, tachycardia will be there, sir. Mostly due to anemia, tachycardia will be there, sir. And
Okay.
that you should look for any tachypnea because in case of acute chest syndrome, there will be distress tachypnea that can be there. So we should look for any tachypnea or distress is there or not there, sir. Then we'll look for after that you could go for that bony and abnormalities are there, no, sir. In case of extramedullary hematopoiesis, there are chances of period frontal brushing, parietal brushing, then sir, malocclusion of teeth, overcrowding of teeth, if there is present or not, sir. Sir, because the child is presented with pain in the lower limb, sir, we should look for the joint in if there is any swelling, there is arthralgia or arthritis, sir. Any
so
inflammation,
Praveen,
swelling,
before
redness.
going into this much detail, any comment on the look of the patient?
Yes, sir.
Yeah.
Yes, sir.
First, when you see the patient in OPD only, any specific comment?
Yes, sir. It is sick look or normal, sir. Because if it is normal look, sir, it is it is due to anemia and it is a painful crisis. That's why. And sick look, it must be due to sepsis, sir.
Not even painful crisis will have a sick look kind of picture. They will be excruciating pain in sickle, right?
Yes.
So they won't be happy faces or normal faces.
I think
If you see,
very simple. Any person with the pain, whatever may be the reason for the pain, even on the screen, we can make out that that person is not happy, even before examination. In the clinic, I think as a clinician, we should be able to interpret. You know, with these type of description, we are not expecting that the child will be comfortable, right? So child is going to be have the sick looking. You should look for in with fever also, right? Even you should look for the dehydration. You should look for the jaundice. You should look for this even the pallor. You should look for the various because chronic, mild but this continuous hemolysis. So as a part of hemolysis, what findings already you are describing, right? Maybe the hyperpigmentation or something. Maybe even extravascular erythropoiesis, if at all, if you get it. Very important that in what way the bone is involved, that you would like to check, right? Even regarding the liver and spleen, and according to the crisis involvement, if there is other systems are involved. But I think these are the points which should be in your mind. If you are knowing, you will check it. And if you check it, you will get it. Sometimes why people, I will say the point is missed because the person does not know. If I am knowing and if I check it, you are going to get it. Therefore, the purposefully I ask this question that before even the examination, I will make up my mind that these are the likely issues with this patient, and I will check my findings that how many points are present as per my expectation and whether they are there or not. That purposefully I should check it. And when you are going to check purposefully, unless because you are knowing. So that was my idea that sometimes people will ask this question that what you are expecting. Anyway, I think sufficient time we have taken to sensitize all of you for this type of the discussion. Dr. Vibhav, should we go for examination?
Yes,
Because
yes.
already
Correct. You
sufficient
can
time
go
we have
on the
taken.
positive findings
Yeah,
in this
yeah.
patient.
In general physical examination, sir, child is conscious, cooperative, and oriented well
Dr.
to.
Praveen, just
Yes,
summarize.
sir.
Don't go much in detail and only
I
positive
think,
findings.
Vaibhav, let him take some time, I will say. Still, we
Okay.
have the time. 30,
Okay,
40
okay.
minutes we have. And I'm
Okay.
sure that we'll be able to take it.
Yeah, sure.
Yeah. Because he might have not come with that preparation.
Okay,
Yeah.
Uh,
Okay, Praveen, you can take your own time. No problem.
yes, sir. Child is conscious, cooperative, and oriented well to time plus person, sir. Child is well built, examined after taking consent from mother and child himself in adequate light. Vital signs of temperature was 100 degree Fahrenheit, measured in the
Just
axilla.
a minute. Even if you ask the forensic medicine people, whether 6 years old child is competent enough to give the consent,
No, sir.
right? So don't use the word consent. On the contrary, what we do, we take the child in the confidence and consent from the parents. We take the consent from the parents and we take the child in the confidence so that allow you to for examination and become the cooperative. Right. So better to put it this way. Okay.
Pulse is 110 per minute, regular rhythm, good volume, normal in character, and then no radial delay, sir. In respiratory rate, it was 22 breaths per minute, abdominothoracic, and blood pressure was 106 by 82 mm per Hg, measured in the right brachial artery in sitting position. And anthropometry, height for age is 10 to 50th centile, weight for age 10 to 15th centile, and BMI is between 10 to 15 centile, sir. In head-to-toe examination, hair was normal, dark hair, no hair loss, no frontal washing, parietal washing, or no malar prominence. Eye pallor was present. In ear, nose, oral cavity was normal. No evidence of any angular stomatitis or no history of cheilitis. Tongue was normal. Teeth was normal. No overcrowding of teeth. No malocclusion of teeth. Skin pallor present. No hyperpigmentation. No knuckle pigmentation was present. Upper limb was normal. Nails normal. No history of choleonychia. Lower limb, chest, spine, back normal, sir. And pallor was present. Icterus was seen. Cyanosis absent. Clubbing absent. Lymphadenopathy not seen. There was no edema. External genitalia are normal, sir. Looking to my history and general physical examination, I want to examine abdominal system first. In systemic examination for abdomen inspection, abdomen is normal in size and shape. Umbilicus is central and inverted. Corresponding quadrant moves with respiration. No visible pulsation, no dilated veins, and no scars. Anal orifices are normal. In superficial palpation, inspectory findings are confirmed. There is no local rise of temperature, no tenderness, no guarding, no rigidity. On deep palpation, liver is palpable, firm in consistency with smooth surface and sharp border, extending 3 centimeter below right costal margin in mid-clavicular line. Liver span was 12 centimeter. Spleen is palpable in the mid-clavicular line in left hypochondrium, which is firm in consistency with smooth surface, sharp border, and it moves with respiration and extend 5 centimeter below costal margin towards umbilicus. On percussion, dullness in the right hypochondrium extending 3 centimeter below the costal margin in the mid-clavicular line. Liver span is 12 centimeter with no evidence of fluid. Dullness in the left hypochondrium extending 8 centimeter along the line joining costal margin to umbilicus. In auscultation, vowel sound is heard. In musculoskeletal system, in inspection, there is no swelling, no redness, no restless pigmentation in any joint all over the body. On palpation, there is no increase in the warmth, no tenderness in palpation in any joint, no stiffness, no loss of power, no restriction of movement, no increase in warmth. In cardiovascular system, pericardium appears normal. Apex peak palpable in seen in the left fifth intercostal space. Medial to the mid-clavicular line, no visible pulsation, scar, or any bony deformity, sir. On palpation, inspective findings are confirmed with apical impulse at the left fifth intercostal space. Half inch medial to the mid-clavicular line, normal in character, no palpable through present. On auscultation, S1 and S2 is heard in all areas. Pulmonary area, high pace of systolic murmur of grade 2, west heard with diaphragm of the stethoscope without conduction and radiations. On respiratory system, normal vesicular with sound heard, bilateral currently equal, no added sound. In central nervous CNS examination, higher mental function normal. There is no sensory deficit and no motor deficit.
Okay, I think can you stop sharing?
Sir.
Dr. Weber, can you take this examination in details for the discussion with them?
Yes, so on general examination, I think your findings are very well correlating with a patient of sickling who presents with acute crisis. So that's fine. So what about going to the systemic findings in a 6-year-old sickle? What you expect to the liver and spleen should be?
In 6 years, most of the times, our spleen should be not palpable at that time, sir.
Right.
It's a
So coming to this case, 5 centimeter below the costal margin, spleen in 6-year-old. What should be your thought process? Now, initially we were suspecting painful crisis. Now the diagnosis will be the same or it will change differential diagnosis.
differential splenic sequestration crisis may come into the picture, sir. And in aplastic crisis also splenomegaly can be, yes, mostly in splenic sequestration.
So then what other parameters will change?
Sir, there will be severe pallor will be there, sir, and there will be anemia. Due to anemia, there will be tachycardia and sign of CCF will be there. Tachypnea can be there, sir. And also there should be child should be presented with pain in the left quadrant, sir. Severe pain will be there due to splenic sequestration. And child should be looked dehydrated because of that pooling of the blood to the spleen. See, it got sequestrated there, so their blood volume will be reduced.
So sometimes hypotension can also be there,
Hypotension will be there, yes, sir.
right? So blood pressure, tachycardia, signs of cardiac failure, hepatomegaly will be there, tender hepatomegaly, what we see in congestive heart failures. So this will add to your parameters, right? Suppose if I say this patient does not have any of these symptoms of CCF, so sequestration or aplastic crisis, everything is ruled out, even no severe pallor. So what other thoughts coming to your mind? Anything related if diagnosis is questionable, is it possible?
The chances of leukemia, sir, organomegaly is there, sir, and also in case of invulnerable metabolism, also organomegaly.
Okay. So leukemia, yes, we have to look because this is a fever with joint pain with hepatosplenomegaly. You should look for the leukemia. But I was thinking the patient was labeled as a sickle and this much spleen, even if 6, 7 years, there sometimes we, as a hematologist, we see these cases routinely. they come to us at first time with the sickle, like splenomegaly. What we should do first actually in these cases?
Uh, we should look for any transfusion dependencies. So it might be compound heterozygous, so thalassemia can be in
Right.
inadvertent.
Exactly. So sickle beta thalassemia is very common. Actually, what we see with such a huge splenomegaly in elder child, not even younger at diagnosis, sometimes they do have a good spleen, but elder child coming to us. So first thing we have to confirm about the diagnosis. So again, we have to look for parents electrophoresis. Sickle beta thal sometimes presents in both ways. As I told you, sickling से भी present होते हैं, thalassemia से भी present होते हैं, right? And second is the inadequate treatment, any form. So it will stimulate extramedullary erythropoiesis and it will lead to the splenic enlargement. Right? Anything from your side, sir, to add?
Okay, I think in general examination, Praveen, you mentioned that there is no hyperpigmentation, no cheilitis, no other findings. What does it indicate? Is it good or bad?
It is a sign of generally it is a sign of the vitamin deficiency, sir. In case of anemia, also it can be due to B12 deficiency or
So
folate deficiency.
what is my specific point? Even you say, what is the cause for hyperpigmentation in the children? Suppose if the hyperpigmentation is there, what is the explanation? Why they develop the hyperpigmentation? Very simple. In any hemolytic process, why there is the hyperpigmentation?
Hemosiderin deposition, sir.
That means it indicates chronic hemolysis.
Hemolysis.
Right. Now, if the absence of hyperpigmentation, if you say there is no hyperpigmentation, so what does it indicate? It's a good or bad?
It is good because child that the skin is our large organ, sir. Any deposition should be started. It will deposition of hemosiderin, deposition liver, cardiac, then skin also deposition will be there. If there is hyperpigmentation in skin, then there is already deposition in the liver and cardiac tissue also, sir.
It's a different story. That probably what is my point? That absence of hyperpigmentation, that means probably not so important, significant chronic hemolysis is there, right? And if it is so, then it's a good or bad for the patient. That means whether the patient is managed properly or patient is not managed from management point of view. What does it indicate? Can you make any comment from not getting these findings?
And not managed properly.
If not managed properly, then
so,
on the contrary, chronic hemolysis will be going on, and then hyperpigmentation or other manifestations will develop. So two things, either some factor is protecting the child, and that can be with a combination, possible, or really some mild variety. But the not presence of all these findings indicate that at least continuous of chronic hemolysis is not there. That is one point which you can make it. Second point regarding liver, you mentioned this liver sharp border. What does it indicate? Any condition, not necessarily here, I would say hemoglobinopathy, but any patient is having the liver, and if you're really finding is correct, it's a sharp border, what does it indicate? Normally, what type of the border we get it? I'm coming to this point because in the exam, some examiner is going to catch us. This liver is enlarged, it is form inconsistency. That means it indicates again some chronic condition. That's right, I agree. You know, sharp border indicates cirrhosis. Is it cirrhosis in this patient? No. So probably our finding is to be confirmed. And that will be the rounded disorder. Sharp, if you say that indirectly you are indicating cirrhosis. That's why I'm telling you that on our findings, somebody is going to ask the question, which we should be aware of it. Second thing, 12 centimeters span in 6 years old child is normal or abnormal? That means what is the normal spine for 6 years old child?
Up to 8 centimeters, sir. 7 to 8
So-
centimeters.
Yeah. So
7 to 8
definitely 12 centimeters, you can say it's an enlarged liver. Now regarding spleen also, you said 5 centimeters. 5 centimeters spleen in sickle, if you say, probably not convincing, right? So in here, we have to have some probable, swallowable, palatable explanation if we stick to our diagnosis of sickle. But is it so that in India, some of the people have got that, yes, with the enlarged spleen also we get even the sickle. I don't know, but I'm learning from some hematologists, probably Mamta Manglani madam many times mentioned that in Indian population, you may get it. Somehow they don't have the explanation, but possible. So what is my point? That we should have some idea when you are going for the discussion, right? And I think most of the other points are mentioned. Why are expecting, suppose in a case of splenic crisis, this cardiac failure and other manifestations, Praveen? Why you are expecting?
Because of pooling of blood to the splenic canaliculi.
I will say, you know that 3 gram hemoglobin iron deficiency, you must have seen the patient is walking very nicely. No any sign of cardiac failure. And here this hemoglobin may be 5 gram, I would say sickle, but still the patient is cardiac failure. Why it happens so?
Because of this onset, sir, splenic sequestration is acute in onset. But that,
very good, very good. You know, any acute hemolysis or acute condition will manifest with the cut because heart is not prepared to face this situation. That is another principle of, I would say, philosophy in the life, medical science I'm talking, which is applied at so many places. Any chronic disease, if it develops in a span of the long time, the body is trying to adapt that situation. It gets a time, and therefore the not manifesting in a bad way. Suppose in a case of hypertension, hypertension develops slowly. The person does not develop any manifestation unless somebody measures the blood pressure. But suddenly, suppose there is the hypertension, that it develops the acute manifestations. Similarly, cardiac failure, similarly for anemia. So here I think you know that acute hemolysis, acute crisis, it's an acute condition. And therefore heart, that they don't get the time for adaptation. Therefore they go into failure. But when the slowly process iron deficiency anemia, that in a long span of the time hemoglobin reaches to 2 or 3 gram, body is able to adapt that situation. And one more point for the management of such patients. Don't go for, I will say, aggressive management in this patient. Aggressive management also invites a trouble because body has adapted in the long span of the time. So it requires even again some sufficient time for the disadaptation. Blood pressure, my target should not be bring it down to the normal. On the contrary, that will invite the trouble in the long span of time. So I think these are the very good explanations which you have given, and we should be knowing it makes a difference. So I think ultimately we have come to put on the examination also. I think you must have some investigations. You can take the investigations. You have any investigation, presentation, PPT?
Not included, sir.
Okay, you have not prepared the slide, but whether do you know the investigation so that we can discuss with Dr. Vaibhav?
So suppose now this is a patient, what investigation you are planning to do?
Yeah, discuss in this way that what we will plan. Yes.
Sir, first of all, we will investigate the patient with complete blood count, sir. CBC, we will go for CBC. Then
And what you are expecting in
what
CBC?
you are expecting, I think that's the point. Yes.
Yes, sir. A degree of anemia will be there, sir. But in case of painful crisis, that will be not that much severe. Or in case of splenic sequestration crisis, it will be lower, sir. It will be like 2-3 gram will be there. Severe anemia will be there, sir. In
Right.
aplastic crisis also, severe anemia will be there, sir. In other sickle cell syndrome, there will be anemia, but that will be moderate, like around 6 SB will be there, sir. And also it will be in peripherals, means a normocytic normochromic anemia most will be there in sickle cell, and sickled RBC will be there, sir. MCB count will be in normal then, sir, in this case. And then we will go for retic count, sir. We should look for
Dr. Pravin, have you seen at any time the smear how their sickle cell are looking like?
sir, sickle cell, they will be there will be polychromas here, sir.
Now, how they are looking? Why they are named as sickle? What do you mean by that?
That because in paddy field we caught that paddy rice with that sickle, sir. That will be shaped like sickle, sir.
Why it happens so? What is the mechanism? Why that
Concavo,
shape is due to what mechanism it is converted in that sickle shaped appearance?
because RBC become rigid, sir. That's why.
Yeah.
And also there will be membrane oxidative stress will be there, sir. That's why become concavo convex types.
Okay. But why they're getting in that particular shape? That means something is stretching them at the extreme, and then the membrane is getting that shape, something like that. Anything happens to that nucleus material?
They'll lose their, sir, microvesicles, sir.
Okay. Anyway, what happens to, in the CBC further?
Yeah, and always it is normocytic
Yes, sir.
normochromic.
No, sir. Sometimes if there is a compound heterozygous, then it may cause to, sir, microcytic hypochromic also, sir.
Yeah, you sometimes we see microcytic little bit, not severe microcytosis like what we see in thalassemia syndromes or severe iron deficiency, but borderline low microcytosis we usually see. Can they present with macrocytosis also?
Uh, yes, sir. If there is chance in fish production, then macrocyte will be there, sir.
Sorry?
Because of this is hemolytic anemia, sir, so chances of macrocyte also be there. Some.
Anyone else can answer?
Yeah, that's not responding much.
Sometimes you see little bit macrocytosis also because as sir discussed, these are very highly cellular turnover is there in all this chronic hemolytic anemias. So even though they are on supplements, sometimes they are having a relative B12 folate deficiency is also going on. Sometimes their transfusion received and alloimmunization is also happening. So because of that allo antibodies, some immune mediated hemolysis is also ongoing hands in hands. So these are the scenarios where sometimes you get little bit of macrocytosis also in these cases, right? So if diagnostic CBC in a sickle cell, yes, I will usually see more kind of a normocytic normochromic anemia, but on follow-up, usually not. Even the hydroxyurea, if they are on adequate treatment with hydroxyurea, usually it is a trend, it is a drug-induced scenario where you will see a macrocytosis. So it's an indirect evidence you can confirm the compliance of the patient. If whether patient is taking well or not, their hemoglobin is always going to be stay around 8 to 10-ish. But the change which you will see is another changes in the MCV, right? With hydroxyurea, their MCV goes towards little bit higher side. So in that case also your MCV goes up. So this can happen. So this has to be also kept in mind, right? Then going ahead with complete blood count, what other parameters?
We will look for the WBC count, sir. It is high or low, and we will look for absolute neutrophil count also, sir. If patient is on hydroxyurea, we should monitor ANC count also, and platelet also, sir.
So what you are expecting in this patient with WBC counts?
Sir, fever is there, so due to inflammation and infection, it should be elevated, sir, mostly.
Okay. And suppose this patient didn't have the fever, only pain in lower limb. What will happen to WBC count?
It should also increase, sir.
And at diagnosis also, what happens to WBC counts? Asymptomatic 1.5-year-old patient coming to you with mild anemia, what sickle or any hemoglobinopathies per se, I will say, you expect WBC counts to be?
It should be raised, sir.
Why it is raised?
Uh, because
There is no infection, there is no fever. Then why it will be
stress induced, sir.
raised?
Because it is a stress to body, sir. That anemia is a stress to body in view of stress, and also bone marrow is functioning. Try to catch up with that. That's all.
So here we have to look for nucleated RBCs and corrected
Yes.
WBC counts also.
Yes,
Sometimes in chronic hemolysis, you see a leukocytosis because of the nucleated red blood cells, which is evidence in hemolytic changes, right? So lymphocytic predominant versus neutrophilic predominance, that's how it helps. In acute chest syndrome, where we are suspecting bacterial or some other way inflammation is more, neutrophils are more predominant. But in thalassemia major, sometimes they presents with 1 lakh WBC counts also, right?
Let me mention now what Dr. Vaibhav has, I will say, discussing, very important for even general pediatricians. I think 3-4 years back, I received one patient from the Bhuj, Kutch, that the child is about 8-10 months old child. And the child was having the hepatosplenomegaly. Hemoglobin was significantly low. And count was some 80 to 90,000. 75 to 80% lymphocytes was reported. And then obviously the pediatrician considered it's a case of leukemia and referred to me in the GCS Medical College. Very important basics, if you know, that's why I'm discussing that when the child is not having the fever, child is even the bad looking, not even the sick looking, which generally we are discussing. Child is not even having the lymphadenopathy or any other findings. I think leukemia is not convincing. Later on, what problem in the interpretation we got, nowadays, this problem was not there when we were students. Because this cell counter was not there. And therefore, in the Newbar chamber, this hematologist or the pathologist has to do. And therefore, this is one of the examples that when you are replacing the human brain with the machine, mistakes are going to be there. Now, in the machine, what we have adjusted, that this number of the size of the cell with the nucleus, that is all these are the leukocytes or lymphocytes. That we have failed in our mechanism. Now, in a case of severe, I would say thalassemia or hemolysis, all these premature RBC cells are in the circulation, late normoblast or normoblast. They are nucleated, they are larger in size, and the machine is not able to differentiate that this is RBC or the WBC. So machine, all these late normoblast, they are considered as the leukocytes. And leukocytes also differential count as the lymphocyte. So then the 80%, 70, 80,000 count with the 80% lymphocyte, naturally, obviously, somebody will interpret this leukemia. But if you go for the peripheral smear examination, there will be evidence of hemolysis. And good pathologists will go, good hematologists will go for correction of this leukocyte count. They go for the correction. I remember in my college, later on the hematologist talked to me that the corrected cell count is like this. And we work up further, turn out to be the case of thalassemia. Even parents work up faster. So I think very good point what Dr. Vaibhav has raised, that this type of the misinterpretation, if you are not aware, is quite common. So we should go in the, and for that reason, what the hematologist insists, I would like to see the peripheral smear myself. I'm sure if you look into the peripheral smear yourself with good hematologist, I think this confusion is not going to be there. because he is going to get the lymphoblast or something in a case of leukemia. Here, on the contrary, evidences of hemolysis. So that's the, I would say, beauty, and therefore it is said, like I would say, Mamta Manglari, Nitin, and other hematologists, my friends, they always insist that the peripheral examination by myself is more important. As like clinician, many times I will say, unless I have seen the patient, findings may not be reliable, because my findings should be reliable, like that. So it's a very, very important point that we should go into detail. Dr. Weber, you can take it further. Sorry for interruption, but I
No,
thought
no,
that this is very important point.
It's very important, sir. That's why I highlighted this
Yeah.
point, because it's
Yes,
a
yes.
routine practice
Yes, it
where
happens. So.
this leukocytosis is misinterpreted.
Yeah.
Right. So next step, what will happen to platelet counts?
Thrombocytopenia can be there, sir. Thrombocytosis or thrombocytopenia both can be there. In case of splenectomized patients, thrombocytosis be there, sir.
But here there was a 5 centimeter spleen, so we are more expecting lowish normal platelets.
Yes, sir.
Right.
Why there is
And then
thrombocytosis in a case of the removed splenectomized patient?
Because, sir, platelet are destroyed in the spleen, sir.
Absolutely, very good. You know that this ultimately these cells are removed from the body by the spleen. When the spleen is not there, the thrombocytosis is possible, and that we should know. Even similarly, you know, in a case of even the celiac disease, they say that the hyposplenism is known. How it happens? The spleen is there, but the hyposplenism. In a case of celiac, it is known, and there's the thrombocytosis. So I think when the thrombocytosis, thrombocytopenia, we should be able to correlate that what happens. As Dr. Vibhav said, here this much enlarged spleen, and therefore platelets, we are not expecting thrombocytosis, either normal or low. Right? Please take it further.
next, what will you look for?
Sir, next we'll go for retic counts. After next we'll go for peripheral smear. Then in peripherals, after peripheral smear, retic counts, sir.
And what you will look for in peripheral smear?
In peripheral smear, sir, in RBC morphology, sir, we will look for that it is first normocytic, normochromic, or hypochromic, sir. Microcytic hypochromic. We will look for that. Then we will look for sickle cell RBC present or not there. Then we look for any polychromasia. We look for any macrocytes, megaloblastic picture are there, not there, sir. Then in WBC series, is there is in also RBCs are nucleated RBCs present or not. We will look for that. And then in WBC
just we mention, Dr. Praveen, for all the students, in the DNP, you know, there is the OSCE. In the OSCE, they are keeping one particular slide. In the slide, sometimes they will keep the sickle cell. And then on that base, they will ask the questions. Identify the abnormal RBCs or something. Then maybe the sickle, and relate to the sickle, they will put the question. So I think these are the OSCE pattern also you should know. And that is very common. They may put even the sickle because, you know, they are totally abnormal cells. Very easy to identify. And then they will put it. Or even sometimes atypical lymphocyte in a case of Epstein-Barr virus. Or sometimes the blast cells in a case of leukemia. Or sometimes with various malarial parasites, calciferopathy vivax to identify. So this is just to sensitize you from the exam point of view, that they can ask these are the different OSCEs even. So with that, we should be aware of it. Okay, Weber, you can take it further, please.
So mainly you will see a RBC series where you are going to look for sickle RBC as well as the evidence of hemolysis. So it will be polychromasia, it will be nucleated red blood cells. You will see some target cells also sometimes. Like that, changes of chronic hemolysis you will see. WBC, as we discussed, depending on the patient's underlying condition, neutrophilic predominance or lymphocytic predominance we will see. And platelets, because it is so much hypersplenism, we usually see platelets in clumps, or if it is thrombocytopenia, we will see the giant platelets because it's a type of a peripheral destruction which is happening in hypersplenism. So that is the thing which we will look for. Then next set of investigation.
then we'll go for retic count, sir.
Okay.
Because of hemolytic disease, in retic count, if in case of aplastic crisis, there will be reticulocytopenia with splenic enlargement. In case of splenic sequestration crisis, sir, it will be reticulocytosis with splenic enlargement, sir. So that will differentiate in between them also, sir.
And what will happen in painful crisis?
In painful crisis, there will be, sir, reticulocytosis will be there, sir.
But borderline, not very
Borderline, sir.
evident like what we see in autoimmune hemolytic
Autoimmune,
anemia or
yeah.
hereditary spherocytosis. It won't be that much evident.
Yes.
Okay, next.
Next, we'll go for if pain. We will for chest X-ray, sir. If there is any chest pain or anything, cough will be history will be there. Then we will go for LFT, RFT, sir, because RFT will be maybe deranged in this case.
Okay.
Then, sir, urine analysis we will go for, and if there is any transcranial Doppler option also there, we can go for that also, sir. For screening
During
of
acute
for
painful crisis, you will go.
no, sir. No, sir. For screening purpose.
So we are talking about acute painful crisis. So what will happen to
Then,
LFT? Which parameters will be altered?
sir, SGPT will be altered, sir.
And
Then direct bilirubin, sir. It will be altered.
indirect
sir.
hyperbilirubinemia will be there.
Yeah. Yes, sir.
Right. Then, and in renal function,
We'll look for dehydration, sir. Urea, in case of dehydration, prerenal AKI can be there, sir. So urea can be deranged, sir.
create.
Create may or may not be deranged, sir. If sickle cell nephropathy, in that case, it can be deranged, sir.
And but suppose it shows the hematuria. Why there is hematuria? I examine the urine and it shows the hematuria.
Sickle cell nephropathy, sir. It will
There is no nephropathy. Creatinine is normal. What I mean to say, is there any specific reason for simple hematuria in a case of sickle? Many a times in nephrology, this is the somehow beauty of the super specialty. I'm really sorry, Vaibhav.
No, sir, it's fine.
That patient of hematuria will go to the nephrologist. Nephrologist will try to investigate in his own way. He does not get any cause related to nephrology, but hematuria is there. And then it turns out to the hematological condition. And suppose sickle. So now how the sickle causes the hematuria? And therefore may not be the other manifestations. Simple, just hematuria. May turn out to be the sickle. It causes papillary damage. And the papillary damage may not be the other manifestations, even renal functions may be normal. And many times the people say that even the unilateral hematuria you may get. Because papillary involvement may not be on the both sides. Systemic disease involvement will be both the sides. So I think really this is the beauty of this medicine, that if you know, it has, if somebody asks me, I have seen only one patient that presented the hematuria turned out to be the sickle without much manifestation. Anyway.
Yes, sir, you have very well pointed out. Sickle is present with so much heterogeneity.
Yeah.
I have seen one case presented with retrospective, they were having sickle nephropathy. So, and then they got diagnosed as a sickle at 10 years of age. Yeah. So, very wide variety of presentation. There is no standard that they will present with anemia, they will present with jaundice. They can come in crisis, they can come in sepsis also.
They can come in with a neurological stroke.
They can come with, yeah.
Even at a stroke, they can come.
So, I think all system related conditions and you will have a sickle as a differential diagnosis possible.
I think so, gradually we have reached to the time. We can try to wind up, Dr. Vaibhav.
No, it's so just a brief about how you manage this painful crisis.
In painful crisis, first primary management is analgesia, sir. We will provide adequate analgesia.
Before
that,
we'll
look for hydration.
Hydration is most important.
Yes, sir. Hydration.
So first and foremost, most important step in the management of any sickle crisis is adequate hydration.
Hydration.
As we repeatedly discussed, dehydration is a precipitating factor. So intravascular dehydration is very common. So maintenance of the hydration and is the key to the successful management. Right?
Which type of the
Then comes your
painkillers,
analgesics.
which analgesics are safe to use in sickle? It's a big question.
So we'll start from the acetaminophen group, paracetamol.
Okay.
Then we can give also ibuprofen, NSAID groups. Then can give opioid also, sir. Morphine can be also given, sir. We should not think about opioid addiction in view of not giving that opioid, sir. So we should, in the pain is not getting managed with NSAIDs, we can go for opioids also, sir.
So before the opioid also, we can use non-opioid analgesics also, tramadol and all that.
Tramadol,
So
sir.
there has to be like a step and ladder pattern, paracetamol to start with, then ibuprofen, then add tramadol,
Tramadol.
and then if nothing is working, morphine, and sometimes you may have to go for the fentanyl patch also, right? So that's how you should approach any painful crisis. The pain is genuine. Hydration, if you take adequately care, what amount of hydration you will give?
Hydration, sir, it should give that much that it should not increase the viscosity.
You can go about 1.5 times
1.5
maintenance fluid also. That much amount of fluid is also required. Even though there is apparently no visible signs of dehydration, there is a intravascular dehydration is there in sickle. So you can go higher in the amount of your fluids. So fluid management, pain management. If patient has not been started with hydroxyurea, you should immediately start the hydroxyurea. And if patient is on that, you can escalate the dose or make the compliance. Will PCV transfusion help in a painful crisis?
There is no documented benefit, sir.
Right. So painful crisis, no proven definition, but even after best of your analgesics, if it is not improving, giving a simple blood transfusion will definitely reduce the painful crisis. Right?
I think 2-3 points better to remember. What Dr. Vaibhav mentioned, it reminds me. There are certain conditions in clinical medicine where our clinical interpretation may not be right. The person like me, always I'm insisting for clinical things. But in a case of Fallot's tetralogy, with even in spite of 15 gram hemoglobin, the child is anemic. In a case of sickle, even with this, particularly the crisis, apparently maybe looking at the good hydrated child, it is dehydrated. Go for more fluid. Many times that's a problem, that why the patient is not managed properly, because you say that now there is no dehydration, but still occult dehydration. And therefore this recommendation is there to go for the 1.5 times of the more requirement to the fluid. That may be for that child, may not be the normal child. But for sickle, hydration should be 1.4 more times. Similarly for Fallows, with 15 gram hemoglobin, give the iron. Because if you don't give it, causes the stroke. So these type of some examples we should do, and sickle is a very good example for that reason. Yes, I think anything else, Dr. Weber?
No, sir. I think we can go ahead. Lots of things on sickle, but
many points
for
are
this
there.
Case,
very difficult to complete even in session. I think now for 2 hours also we are finding the difficulty.
Correct.
And sometimes when people find the 2 hours very long time, some people are asking me that what you are doing for 2 hours. I say for 2 hours it's a short time for us. Anyway, definitely. We'll have to end over here. Most of the points we have covered, starting from vaccination. But one point, Praveen, again, I would like to bring to your notice. In spite of the good presentation, one part you have missed, and that is the growth chart. Growth chart should be there in any case of pediatric presentation. Whatever the system, I will say. Or even I will say without system. Even the normal child. Because to say the normal, I would have to look at the growth. And therefore, growth chart is very, very important. Again, but otherwise, I will appreciate that you have selected the good case. Even you have come with a good preparation. You are well prepared. I'm sure that you, unfortunately, your friends were not much participating, and therefore most of the things you have, I will say, done the betting. Then once a country quite appreciable responses were there. Definitely, your I will say that credit goes to your mentor also, Dr. Nisha. And we expect that the more students should come on the screen. Not only the, I will say just your presence, make the video on, even try to answer. Not necessarily always our responses will be right. We should not be afraid of it. But participation is very, and I'm sure that if you participate, that would be the better learning rather than just passive listening. I'm sure that next time more students will participate. And thank you very much. Presence of Dr. Weber made the difference in our understanding the subject, the details, and even this right approach. Thank you very much, Dr. Weber.
No, sir.
Dr. Praveen.
Thank you, sir, so much. We all learned from you. And we use the same platform provided by Amdekar sir and all that
Yeah, yes,
in
yes.
our PG times. So
Yes.
I think these are the wonderful platforms where you can
Yeah.
interact and get a practical knowledge more.
Absolutely.
So very good platform, sir. Thank you.
Thank you. And we should not forget Dr. Nehal and her team that they are
Definitely.
taking so much pain that catching everybody, the presenter and mentor and the I'm easily available, so Nehal, no problem unless I'm some out of that. Because to be
So
very
you are,
previous, if
so you
somebody
are the support. You are the support. Base of the program is you only, sir.
anyway, we'll end over here. Over to you, Dr. Nehal.
Thank you so much. Thank you for today's great presentation, Prabhi. I start from you today because the presenter must be appreciated first. That what I learned now in one of the my another teaching. So generally, I generally thank the expert first and then lastly presenter. So now I have changed it. So Praveen, thank you so much for gathering the courage, for presenting so beautifully, and for being prepared for all the answers. So
Yes.
even though you are wrong, it's okay. But you should, whatever is in your mind, you should come it out with. And thank you, Nisha, for preparing the students so nicely. Although it's a teacher's job and always a thankless job, but students thanks us so much. We don't thank enough to us, but I thank you for preparing the students so nicely. Thank you, Vaibhav. Vaibhav is uh, Vaibhav is always there whenever I ask, unless he is having some other commitment. Otherwise, he is always there to guide the students. Thank you so
I
much.
am sir student. I have learned from sir and I am Dr. Rajal ma'am student. So always open for academics.
I think this is definitely
Uh,
what Dr. Vaibhav said. This is not only the teaching. Of course, we probably having the more some experience and learn. So, but ultimately we are learning. And you know, that is the best method of learning. Go for the interactions. What Dr. Weber mentioned, I am looking at the Ambedkar sir since many years. Even I have participated with him at several occasions. And you know, that is the only process. That's why I said, Dr. Neil, that why I'm easily available because I am interested in learning. Unless I interact with you, unless I'll probably, even suppose if I'm listening to Dr. Weber, I'll be noting so many points. And unless we do it, will not naturally, it cannot be continued. So for this reason, and I'm encouraging the students that please participate without any hesitation. Even the suppose if you are wrong, no problem. Every time, even the no clinician can be right. But at least with our understanding, whatever the understanding, we are trying to explain. And that I would say response should be there. I understand probably initially the hesitation is always common, physiological, but I think the due course of time it should disappear. I think that's very important. Anyway, now it's
yeah.
in
It's
your
time.
hands.
So, my request again to all the students who are joining in this platform, please participate. It's always good to participate, and whatever you are speaking here, whatever you are learning here, if it is discussed face to face, we also enjoy, you also enjoy. So,
Yeah.
please participate with your camera on and whatever you know. Thank you so much. Thank you so much, sir. Thank you, Clarinet, for
Thank
providing
you.
this platform.
Yes. Good
Thank
night.
you. Bye.
Good night.
Good
Thank
night.
you, madam.
Good night.
Good
Good
night.
night.